Welcome to another just-in-time production from RAPM. Today we're talking with Marianne Gausche-Hill. She's a professor of clinical emergency medicine and pediatrics at the David Geffen School of Medicine at Harbor UCLA Medical Center and the Departments of Emergency Medicine and Pediatrics, and the interim CEO of the Lundquist Institute for Biomedical Innovation at Harbor UCLA Medical Center. It's a great pleasure to have you back with us again, Dr. Gausche-Hill. And we're going to be talking today about something that is, I think, critically important in this moment in time, October of 2024, when all of us across the country are dealing with a shortage in IV fluids relating to the hurricanes over on the East Coast. I know our institution is talking seriously about how to marshal our dwindling resources of IV fluids. I think we are definitely not alone. It's part of the national conversation now. And one of the things that has come up in our conversations at RAPM is about, what alternatives do we have to using IV fluids? I think we're so used to anybody shows up and just give them a liter, but this is not
Yeah.
this is not that time,
No.
and there are some alternatives. So specifically, let's talk about those patients that come in with like a gastroenteritis, a pediatric patient who just comes in dehydrated. How do we go about like assessing them, and then what are our options short of putting in an IV and just giving them some fluid because it's free?
Yeah, I think most kids actually who come in with dehydration can be orally rehydrated. We sometimes, for expediency, want to go to IV fluids, but in this time of shortage, as you've already pointed out, we want to save those IV fluids for those who really, really need them. Typically, those with either mild dehydration or moderate dehydration can be rehydrated with oral rehydration solution. And there's some standard ones that you can get over the counter, Pedialyte being a very common one, but you can make your own as well. And we'll talk about that in just a bit. But I think one of the first things you have to decide is how dehydrated are they? Certainly some things that are just really obvious. A child who is drowsy, limp, not responding, not interacting with their parents. Their eyes are sunken, mucous membranes are very dry, their mouth is very sticky, and absent tears. We're very concerned that that patient is going to need to be rehydrated, ideally with IV solutions. So that's somebody with severe hydration. Even then, if indeed in poor resource areas or times where IV solutions aren't necessary, an NG tube could be placed in that child in an emergency department and very gingerly, orally, rehydrated through the GI tract. So that can occur. As you know, we would recommend, saving your IV fluids for those with severe dehydration. But again, very poor resource areas, you still could consider it. So for mild to moderate, these are kids that are thirsty, a little bit restless. They could be irritable. Again, the mucous membranes, I said, were dry. They could be a little sticky with decreased tears or poor urine output. You would consider thinking about hydrating them. And then some kids just report lots of fluid loss and they're unable to keep up. So a child that has had tons of vomiting and diarrhea, we think about potentially, at least in the ED, considering giving them ondansetron or Zofran, and that could be given. That's been shown to help them rehydrate because they stop vomiting. Now there are some side effects of ondansetron, which includes diarrhea. So if they're prominent, the diarrhea with very little vomiting, I would not give it ondansetron as an example. So again, with mild to moderate, we don't give antidiarrheals like Lomotil or anything like that as we do in the adult population. We don't do that in kids. We don't recommend treatment for infectious diarrhea at this time. And we would do an oral rehydration solution. Generally, I say about 5 milliliters. You can use a syringe, obviously without the needle, and every 5 minutes or so, you give it, and then you wait. And if they haven't vomited in 5, 10, and some would go as long as 20 minutes, then you can continue to give it. We typically would do, again, the 5 mils, which is that is a teaspoon of fluid, and you can do that on 5-minute intervals as long as they don't vomit. Once they vomit, then you stop, wait for a period at minimum of 5 minutes, as a maximum 20, and then start rehydrating again. So that's kind of my method of doing it. If they're older, let's see, they're not an infant, you can go as much as 10 mils. So 2 teaspoons of oral rehydration solution. Okay. Now, if they're really unable to keep anything down, I would utilize ondansetron, and then I would consider an NG tube. So what we do is we try a PO challenge, just having them drink it. You could use the syringe method, especially for infants. And then if the vomiting continues, then one might consider putting an NG tube. And if they fail that and are unable to keep anything down, then you need to go to an IV. But you can see that really for the large majority of children, that you can orally rehydrate them. The other thing is you teach the parents, you give them the plan, right? The parents, and you say, okay, this is how you do this. And, you can help us. And you teach them essentially the 5 mils per 5-minute rule. And then they do that, and it gives them something to do while they're waiting. And it's also a great way to leverage their help in rehydrating their child.
I feel like we need to title this just in time video, Love in the Time of Cholera, right? I mean, we know this works, right? Because
Yeah.
we saved thousands upon thousands of people with oral rehydration solutions when these were first invented, in the time when there were, pandemics of
Yes.
cholera and no good way to give them all an IV and liters of fluid.
No, you're absolutely right. And it really, it also depends on where you're in the world. In most areas, if it's suburban, even rural areas are going to have, um, you know, markets or what have you, that you can buy oral rehydration solutions, since it's such a common problem worldwide. But there may be times when you cannot get out, or roads are impassable, like what occurred with Helene and Milton, is that some of the roads were not, you couldn't cross. And so you couldn't get to a store. So with that, as long as you have clean water, or you could boil water to make a rehydration solution. And the World Health Organization has several recipes for oral rehydration solution for children. There's a number of resources online, which we'll demonstrate as a part of this just in time. But I think the bottom line is you really could consider it. And we don't often think of that. The other solution, the other issue that comes up in EDs is inability to get an IV in somebody who's pretty moderately to severely dehydrated. And depending if they're actually in shock, you could use an intraosseous device. But really, without the presence of shock, anybody would hesitate doing that. So you really should think about oral rehydration through an NG tube as a potential option. Certainly trying it orally without an NG tube first, but if indeed the child is more ill than that and unable to even help through swallowing, an NG tube is an option.
Fantastic. I mean, as a surgeon, my initial impulse with any child is just make them NPO. But I think this is a great example of a time when that is absolutely the wrong way to think about it, right? Like they have a perfectly good intestine, go ahead and use it.
Right,
Now,
right.
say the upper GI tract is not working great. So we've got a patient with a lot of vomiting, not with diarrhea. Is there any role for rehydrating enemas? I know that I've read about them in the past, but are we doing that these days?
I have not. Hypodermoclysis is something you could consider doing. So you clean, between the shoulder blades, right? That area between the shoulder blades, you not over the spine, but just adjacent. And you clean the area, numb it, put in a butterfly, right? Needle under the skin, and you could do hypodermoclysis
I did
as
that with the
another.
cat once. Yeah.
Yeah, I mean that's the way they rehydrate animals all the time. They generally use a little bit of hyaluronidase that kind of helps break up the tissue to create a space. But that has also been touted, hypodermoclysis, as an option. I have not done it, but I had a colleague who did it. Um, and said it
It
worked
probably,
great. I mean, the kid gets kind of a hump and it gets
yeah.
red for a while, and you think, oh my gosh, what have I done? But then it's just absorbed.
It's probably
So,
taking us too far off topic because, like, you would have to use IV fluid to do that, right? So maybe let's
yeah,
forget I
that
ever
that's
raised the
true.
issue.
But again,
Yeah.
what I'm talking about are people that
Like, you can't get an IV.
you can't get an IV. It's actually an option. I would probably go to the gut at this point. I have never given, I mean, it makes some sense. Part of the problem is it just drains out. So you'd have to, I don't
Right.
know
Like, how
how
do you,
that would
like
work.
a retention enema? Like, how do you
Yeah,
keep it in? Yeah. Okay. Sorry, I was getting creative.
that's okay.
History's come all the way around again, and we're talking about
Yeah.
oral rehydration. What's old is new again in these exciting times we're living in. Thank you so much, and what an invaluable resource for patients and providers who are out there looking at a dwindling stock of IV bags.
Oh, thanks so much for having me. Everybody be well.